Bismillah ar-Rahman ar-Rahim. Now we are discussing the last topic in this day, which is the MRI imaging of the hip joint. Then, as we used to handle the joints by MRI, we start first by the indications, and the indications will include the local joint complaint, which are almost similar for any joint: pain, trauma, and swelling with suspected infection or tumor. Then if you are going to inject the patient with contrast or to sedate the patient should be fasting for 4 to 6 hours. Then put the patient in the supine position and use the body coil to image the pelvis and the hip joints. Then these are the MRI machines. This is the extremity magnet, which is not suitable for the hip, but suitable for the knee, ankle, elbow, and the wrist, as you know. Then a few words about the common appearances in MRI. What are the structures that appear low signal in the T1 and low signal in the T2? They are fixed structures containing non-mobile protons, including the cortex of the bone, the mature fibrous tissue, and the calcification. And add to this, in particular for the hip, the acetabular labrium. Then the structures which appear high in the T1 and low in the T2, which are the fat, and the fat is located in the bone marrow, is located subcutaneously. The opposite of the fat is the fluid, and the fluid appears black in the T1, like the fluid in the urinary bladder, and bright in the T2 within image. Then how to know the pulse sequence for the non-radiologists. In the T1 weighted image, the bone marrow is bright because of the fat signal. In the T2 weighted image, it is less bright, and in the gradient image, it is less bright and is very dark in the stir image. All these three images belong to the T2 weighted image, where the fluid will appear bright. Then how to examine the hip by MRI. We start first by the axial scout, and we should have coronal, axial, and sagittal. Actually, we depend mainly on the coronal for the diagnosis, and we usually should have the coronal T1 and the coronal stir images in order to assess the bone marrow abnormalities, particularly of the humeral head, of the femoral head. Then we should have an axial T1 and the T2, or you may have axial proton density and the T2, or you may have axial T2 and the gradient. All these can fit with the protocol. Then you look to the diseased hip and have a sagittal better to be a T2 weighted image. This is the coronal T1 weighted image, this is the axial T1 weighted image, and this is the sagittal stir. Then the anatomy of the hip is very simple. There is no much anatomic details here. The hip is a ball and socket joint. The acetabulum covers about 40% of the femoral head, and the labrium, which is a fibrocartilaginous, appear black in all pulse sequences, increase the depth of the acetabulum. 95% of the femoral neck occur inside the joint, which is intra-articular in location. Then these are the most important muscles around the hip you should know in the anatomy. The other muscles you can go to the book and know its name exactly. First of all, the most important one is this one lining the inner aspect of the iliac bone and the acetabulum, which is the obturator internus muscle. This is the obturator internus muscle, the two components of the muscle. Then the muscle lying against the superior pubic ramus, which is the pectineus. The muscle adjacent to the femoral neck is the iliopsoas muscle, and the muscle above it directly is the rectus femoris, and this is the tensor fasciae lata muscle, and this is the vastus lateralis, and this is the sartorius. These two muscles are of less importance, but these muscles are very important. Also the gluteus maximus muscle. In the coronal images, there are three muscles which are very important. The obturator internus, they form like a fan, and you see the obturator internus and the obturator externus muscle and the abductor brevis muscle. Actually, these muscles are very liable to injury, especially in the players who use frequently the hip joint in cycling and any other gymnastics. Then also, by the way, you can remember that this is the adductor longus, and you also know that this is the gracilis. Then what are the items to be evaluated? In the hip, because of the limited anatomic details, we use the pathology as the map for assessment of the hip. Then what are the most common pathologies occur in the hip? Here is the vascular necrosis of the femoral head, the transient or migratory osteoporosis, Bursa's disease, which is a vascular necrosis in the pediatric age group, a slight decapital femoral epiphysis, the trauma and muscle injuries. Then few ancillary items like the labral tears, the bursitis, the loose bodies and osteochondromatosis, and lastly, how to measure the femoral neck anteversion angle. Then we start by the most common lesion that is for which the hip is usually examined by MRI, which is avascular necrosis. Avascular necrosis affects the femoral head, and the MR sensitivity and the specificity, as you can see. These are the most common causes of avascular necrosis of the femoral head, including trauma, corticosteroids, sickle cell disease, alcoholism, Gaucher disease, radiation, and collagen diseases. How to diagnose avascular necrosis of the femoral head, or to suspect the avascular necrosis by plain X-ray? Number one, contour abnormalities and the fissures of the femoral head, areas of bone sclerosis and areas of bone rarefaction, structural collapse, and osteoarthritic changes. If you look carefully to this femoral head, and you can see that the head is relatively sclerotic compared to the opposite side. Also, you can see some areas of bone rarefaction, but the cortex is still smooth, and the femoral head is more or less intact with no evidence of structural collapse. But in this case, you can see the full-blown picture of avascular necrosis, including flattening and collapse of the femoral head, fissures and fractures, areas of sclerosis, areas of bone rarefaction, and osteoarthritic changes of the affected head. Then the same findings can be seen by CT, but nowadays the most important imaging modality is MRI. The CT findings include contour irregularities and fissures, areas of bone sclerosis and osteoporosis, and you can see a structural collapse and osteoarthritic changes. Then the MRI is, of course, the main diagnostic modality for assessment of avascular necrosis, and according to MRI, we have 4 stages or 4 grades of avascular necrosis. This grade 1, which is debatable nowadays, I will tell you why, is presented in the form of just bone marrow edema of the femoral head, and they consider it as stage 1, and this is no more accurate nowadays. Then, starting from the development of a line, and this line separates the necrotic bone from the normal healthy bone. Whenever you see this line, this is pathognomonic for the diagnosis of avascular necrosis. Then, according to the signal intensity of the dead bone, you have stage 2, stage 3, and stage 4. In stage 2, the necrotic bone is similar to the healthy bone. Okay, and this is stage 2. In stage 3, the necrotic bone is of fluid signal. I mean, low signal in the T1, high signal in the T2. In stage 4, the necrotic bone is sclerotic. I mean, low signal in the T1 and low signal in the T2. These are the 4 stages of avascular necrosis. This is the debatable stage, which is the stage 1, is just a bone marrow edema in the femoral head and may extend into the neck, which cannot be totally discriminated from the migratory osteoporosis. Then these are the stages and the appearance in the radiograph. Stage 1 will appear normal in the radiograph, will show no abnormality, and it will appear as bone marrow edema, which is low in the T1, high in the T2. We'll discuss this after that. Then stage 2, you may get some osteoporotic changes and some osteosclerotic changes in the plain X-ray, and you see normal bone marrow, which is dead, separated by a line from the healthy bone marrow. This normal bone marrow will appear of bright signal due to fat in the T1 and intermediate signal due to fat in the T2. Then stage 3 is fluid signal, low in the T1, high in the T2. Stage 4 is bone sclerosis, low in the T1 and low in the T2. Then look at this images. This is the T1 and this is the stair. If you see the line, you are dealing with a vascular necrosis. Then look to the bone marrow bordered by the line. If it is similar to the normal marrow, do not go to the T2 weighted image. This is a T2 or stage 2 avascular necrosis. If you look in the stair or in the T2 weighted image, and you will see that the bone is normal because of the suppression of the fat here, like the suppression of the fat in the normal bone. And here, then you can see here a line which is bordering a bone, and this bone showing normal signal to the rest of the femoral head. Then you are dealing with a stage 2 avascular necrosis. And this is a stage 3, where there is a line bordering an area of low signal in the T1 and high signal in the T2, means fluid signal. Then you are dealing with stage 3. Then look at this plain X-ray and MRI. In the plain X-ray, you can hardly see a lesion. This arrow points to some sclerotic area here, but the femoral head is smooth, there is no collapse, and then in the MRI T1 weighted image, you got a line. Then you are dealing with a vascular necrosis. The bone inside the line is almost similar to the bone outside the line. Then you are dealing with stage 2 avascular necrosis. Also here, and you can see in the line, you are dealing with stage 2 avascular necrosis. The prognosis depends on many factors: the size and the location of the lesion. Lesions, as stated in the literature, lesions less than 25 of the weight-bearing area of the femoral head will respond well to the core decompression. And medially and centrally located lesions have better prognosis than the peripherally located lesions. Contrast injection, this is a way that was used before to assess the viability of the bone, and is no more of value. Then if you look to the plain X-ray, and you can find the changes of avascular necrosis in the form of contour irregularity, areas of sclerosis, areas of rarefaction. Most of the books states that there is no need to do an MRI, but this is the MRI of the same case, and you can see this area of bone bordered by the line. It's black in the T1. Then you should have the T2 weighted image to see if this will become bright. Then you are dealing with fluid signal stage 3, or still black, then you are dealing with bone sclerosis stage 4. In the CT scan, you may predict the diagnosis of osteonecrosis or avascular necrosis of the femoral head by the presence of bone sclerosis and areas of bone rarefaction. And this is actually stage 4 because of the collapse of the femoral head, sclerotic areas, and areas of bone rarefaction. In this case, there is no need to assess this hip by MRI, but you should do an MRI for the opposite, apparently normal hip, because the avascular necrosis is usually bilateral, and it may be stage 4 on one side and stage 2 on the opposite side. This is stage 4 avascular necrosis, MRI T1 weighted image, and you see the black signal of the necrotic bone, which persisted as black in the stair image, denoting that the development of bone sclerosis. Then if you look here, and you can see a line. This line is very important to judge the presence of avascular necrosis. Then look at the bone bordered by the line. It is black in the T1, and most of the bone is still black in the T2, except for a small area which showed fluid signal. Then this is a stage 3 passing to a stage 4 avascular necrosis. And this is a stage 4 avascular necrosis, T1 weighted image and T2 weighted image. The dead bone appears black in both pulse sequences, apart from a small area of fluid signal. Then we came to the transient osteoporosis, which is a disease of unknown etiology, and it occurs by this incidence. Males are more commonly affected than females, and is usually a unilateral disease, not a bilateral disease like avascular necrosis, and it may resolve spontaneously in about 6 to 8 months without treatment. The patient usually complains of pain and limited movement of the affected hip. What you can see in MRI is just edema of the femoral head and the neck. Also remember that avascular necrosis affects only the femoral head, but this disease affects the femoral head and the neck as well. Bone marrow edema will appear black in the T1 and bright in the T2 weighted image. This is the axial T1, the head and the neck are affected. This is the axial T2, the head and neck are affected by edema. And in bone scan, you will got increased uptake in the affected hip. The opposite is seen in avascular necrosis because of the cutting of the blood supply. You got a photopenic area in the affected hip. On MRI, you can see a bone marrow edema in the femoral head and the neck, and bone marrow edema in the femoral head and neck, which is bright in the STIR image. Also, some synovial effusion is usually present in the diseased hip. Then look at this case of a male patient, 31 years old. MRI T1 weighted image, the femoral head and neck shows edema. MRI T2 and the STIR showing edema, bright signal in the T2 and in the STIR. Axial T1 showing bone marrow edema, axial T2 showing bone marrow edema, and you can easily identify the synovial effusion as well. Then, can you see a vascular migratory osteoporosis in the CT or the plain X-ray? You can hardly appreciate the degree of osteoporosis in these two conditions. But on MRI, you can see the femoral head and the neck affected by edema, the femoral head and the neck affected by edema in the STIR image. Then, where is the lesion? Is it on the left side or on the right side? Yes, the lesion is on the left side, and you see a black signal in the T1, bright signal in the T2. This is actually a residual red marrow in the femoral head and neck, which does not change in signal on the T1 and T2 weighted image. There is some synovial effusion here, and also here you can see some synovial effusion. And the MR of this case, you can see bone marrow edema in the femoral head and the neck and the proximal shaft. In the STIR image, you can see the edema and the effusion. And this is the follow-up after, let us say, 3 months. And you can compare the images here and there. There is total resolution of the disease within 3 months. And also comparing the STIR image after 3 months with the STIR image before 3 months. And this is a vascular necrosis of which side? The left or the right or both? Right. Yes, the right one. This is the black, the bone marrow edema in the T1 and in the T2 weighted image. And this is the axial image showing bright signal with synovial effusion. The bone scan shows increased uptake in the femoral head and the neck. The follow-up scan shows the resolution of the lesion on both sides normal, and in the STIR also they appear normal. This is the lesion before resolution and compared to the affected hip. Then sometimes you may be confused between transient osteoporosis and avascular necrosis. Actually, in the beginning of this talk, I said that the bone marrow edema was considered previously as a stage 1 avascular necrosis and is no more considered like this. And the main diagnostic sign of avascular necrosis is the presence of the line. In absence of a line, don't diagnose at all avascular necrosis. Then if you see bone marrow edema without a clearly discriminated line separating the dead and the normal bone, don't diagnose avascular necrosis unless you see the line. Then, can avascular necrosis and migratory osteoporosis occur in the same patient? Maybe. Look at this case and you see bone marrow edema in the femoral head and the neck, and the bone marrow edema in the femoral head and neck, no line. This is migratory osteoporosis. Here you can see a line and you can see a necrotic bone which is bright in the T2 or in the STIR, meaning that you are dealing with a stage 3 avascular necrosis. Then we'll discuss another issue which is also debatable nowadays. Sometimes many patients can got, especially the elderly patient and the patient with certain types of gymnastics. They may got what is known as the subchondral fracture. A subchondral fracture is a fracture in the head of the femur below the cortex of the femur. And if this fracture happens, you will got a line and you will got bone marrow edema. Then you may be confused with avascular necrosis. How to separate these structures from the avascular necrosis? The only sign is stated in the literature is that the line of avascular necrosis is usually facing the cortex, but the line of subchondral fracture is usually parallel to the cortex. And if you have a follow-up study, you will got resolution of the fracture and the resolution of the edema, while the avascular necrosis does not resolve. The avascular necrosis persists. Then look at this example. And this post-traumatic patient, and you can see edema of the femoral head and part of the femoral neck. And this arrowhead points to a small fracture line which is parallel to the cortex. And the fracture line is more apparent in this image and is slightly apparent also in this image. And the follow-up study shows complete resolution of the fracture and complete resolution of the edema. Then, I will summarize these three conditions just now, but look at this entity which is known as rapidly destructive osteoarthritis of the hip. It is an osteoarthritis but progresses very rapidly until it reaches full destruction of the hip. Then you can see in this hip joint that the hip joint space is markedly narrowed, subchondral pseudocystic changes, subchondral osteosclerosis, and you can see the pseudocystic changes in the acetabulum and in the femoral head. Then look at this case also with rapidly destructive osteoarthritis of the hip. The femoral head is totally lost and the acetabulum is almost totally eroded, and you got some sclerosis and granulation tissue filling the joint. Actually, this appearance cannot be discriminated from septic arthritis, for example, of the hip, but the clinical symptoms are very important here to separate both ideas. Then this is the conclusion of the three diseases: the avascular necrosis, the migratory osteoporosis, and the subchondral fracture. This is written in the books. Start with this avascular necrosis is not a manifestation of transient osteoporosis. Then you ignore totally the stage 1 of the avascular necrosis, which is represented by bone marrow edema. Is no more stage 1. Then the transient osteoporosis may progress to avascular necrosis. Patients with transient osteoporosis who are not adequately treated, still weight bearing, and so may develop later on avascular necrosis. Also, the subchondral fracture may not heal and progress to avascular necrosis. Then what about the relation between both? In both conditions, you got edema of the femoral head and the neck. The only difference between these is the presence of the fracture line. What happens if you don't see the fracture line? You will diagnose the possibility of avascular necrosis. And this is the conclusion of these conditions. Then you came to the Bursa's disease, which is avascular necrosis of the femoral head in the pediatric age group. And it is very easily diagnosed by plain X-ray and can be supported by the MRI. Then these are the stages of Bursa's disease, which are not belonging to the stages of avascular necrosis in adults. Stage 1, part of the epiphysis is affected by fissures or erosions or collapse. Stage 2, part of the epiphysis is affected with metaphyseal irregularity, like these metaphyseal irregularities. Stage 3, all the epiphysis is affected and the metaphysis as well. Stage 4, there is flattening and collapse. This is stage 4 of the burst disease. Stage 4 burst disease, flattening and collapse of the epiphysis, then you are dealing with stage 4. Then what do you think about this case? This is a child 6 years old with burst disease of the left hip, and this is the follow-up X-ray after 6 years. This is the initial X-ray, and this is the follow-up X-ray after 6 years. Then you know that the burst disease is reversible, and it can heal over a certain time, and you may got almost normal appearance of the epiphysis. There is minimal flattening, but the cortex is smooth. The metaphyseal irregularities have been resolved. Then this is burst disease stage 4 with flattening and irregularity of the epiphysis and the irregularities of the metaphysis that healed over 6 years. And this is another example with regression of the burst disease over years, over 3.5 years, flattening and collapse, then disappearance, and lastly almost normal appearance of the epiphysis. The role of MRI in burst disease is to assess the presence of is to assess the stages of the disease. Part of the epiphysis is stage 1. This is the normal epiphysis, which is bright signal in the T1 due to the fat content, and this is a stage 1 bilateral burst disease. Here you can see the flattening, collapse, and fissures of the epiphysis with metaphyseal changes suggestive of stage 3 to stage 4 burst disease. And this is totally sclerotic epiphysis of the femur, diagnostic of stage 4 burst disease. Then slippage of the capital femoral epiphysis may occur either spontaneously or post-traumatic or secondary to obesity, for example. And in my opinion, the CT is the most suitable diagnostic way for this lesion. Look at the normal appearance of the epiphysis in its normal location and the slippage of the epiphysis, which is usually occur inferiorly and medially. Then by plain X-ray you can diagnose the slippage of the epiphysis if it is evident, like this one, but sometimes it is difficult to be assessed. And you may use the certain specific lines to reach the diagnosis. The first line is the line drawn tangential to the upper part of the femoral neck, and this line should cut part of the epiphysis. But if the epiphysis is slipped, then this line will not cut any part of the epiphysis. The epiphysis is displayed like this. Also in the frog position, you can easily appreciate the slippage of the epiphysis. In the MRI, I think it is little bit difficult compared to the CT scan. On the CT scan, you can see the slippage of the epiphysis, and here you can suspect the slippage of the epiphysis. And this is a slipped capital femoral epiphysis by CT and by MRI showing an advanced case of a slipped capital femoral epiphysis. The role of MRI in these cases is to assess the viability of the slipped epiphysis, if it is viable or it is the site of burst disease. Then the muscle lesions include the 3 stages. And you remember the 3 muscles here, which are the obturator internus, obturator externus, and adductor brevis. The stage 1 is muscle edema, low signal in the T1, high signal in the T2. Stage 2 is muscle hemorrhage, which is bright in the T1 and the T2. Stage 3 is muscle atrophy due to wasting and so. Then if you look here, this is a stage 1 muscle edema. You see no abnormality in the T1 and high signal in the T2, denoting muscle edema grade 1. Muscle hematoma, grade 2 injury of the semitendinosus muscle, and another case of muscle hematoma, and you can see the high signal in the T1 and also the high signal in the T2. Then the stage 3 muscle injury, you see the rectus femoris muscle here is atrophic compared to the rectus femoris muscle, which is normal. Then you can see the degeneration and atrophy of the muscle. Fractures are easily diagnosed in the region of the hip, especially with the use of multi-detector CT. And you should know that most of the femoral neck is intra-articular. Meaning that if you got fracture here, it's an intra-articular fracture. Bone fragments these bone fragments are located inside the joint. Then if you look to this coronal reconstruction of the post-traumatic hip dislocation and look to the axial images, and you can see posterior dislocation of the hip, the acetabulum is empty from the femoral head compared to the left side, and the sagittal image show posterior dislocation of the hip. Another case of fracture dislocation of the hip with comminution of the ilium. Then whenever you see bone marrow infiltrative lesion complicated by fracture, this is a pathological fracture of a metastatic deposit in the femoral neck and the proximal shaft from a breast cancer. Then where do you think the abnormality in this coronal reconstructed image by CT? Left or right? Right femoral head or ilium or acetabulum? Yes. There is some sclerotic reaction here. Then if you look to the MRI and you got abnormal signal increase in the acetabulum and also in the femoral head. Can you see this? And you can see also joint effusion. Then look to the CT scan and you can see this appearance. You remember in the lecture of bone tumors, and you know that the iliac bone is infiltrated by a tumor, and this tumor is encasing the iliac bone. Then you suspect the possibility of lymphoma, and also any lesion affects the iliac bones in adults, you may consider the possibility of metastatic deposit. Then this is a chondrosarcoma because of the presence of calcium in the tumor matrix, which affects the anterior part of the acetabulum, and calcium is hardly seen by MRI. This is T1 and this is T2, but CT and the plain X-rays can be helpful in detection of calcium. Then few words about the hip arthrogram. And the arthrography of the hip is used mainly for assessment of the acetabular labrium, which is exactly similar to the glenoid labrium, and for assessment also of some cases of loose bodies in the hip joint. This arrow points to the site of contrast injection in cases to do an MRI of the MR arthrography of the hip. You use 0.1 millimeter of gadolinium, 20 milliliter of saline, and 5 milliliter of iodinated contrast material, and also add some local anesthesia in order not to introduce significant joint pain. Then this is the MR hip arthrogram, which is used to detect labral abnormalities, loose bodies, and osteochondral lesions. This is the normal hip arthrogram, and in these cases, after injection of contrast material, you use the surface coil for the hip of interest. You use the surface coil. This is the focal field of view, which is almost similar to that of the knee, and the size thickness is from 3 to 5 millimeter. Use T1 fat suppressed images, and you perform sagittal and coronal and maybe axial oblique images to assess the integrity of the labrium. Then the normal labrium will appear as a triangle of low signal intensity, and you can see the superior labrium here, and you can see the inferior labrium in this area. This arrow points to a signal abnormality at the base of the labrium, which is just indicating indicative of labral degeneration. Then this is a true labral tear with total separation of the labrium from the glenoid labrium, from the acetabulum. Then this is one of the findings which are very suggestive of labral tears, which is a paralabral cyst. The presence of paralabral cyst is highly suggestive that this labrium has been tall. Then a few words about the bursa around the hip. There are the trochanteric bursa, the ischiogluteal bursa, and the iliopsoas bursa. This is the largest bursa all over the body, is the iliopsoas one. The trochanteric bursa is related to the greater trochanter. And here you can see trochanteric bursitis, which is full of fluid that is black in the T1 and bright in the T2. This arrow points to the iliopsoas bursa between the iliopsoas muscle and the acetabular bone. This is the site of the iliopsoas bursa, and this is the appearance of iliopsoas bursitis. And sometimes this bursa is communicating with the joint space, and if the joint space contains fluid, it can be decompressed in the bursa itself. As written here, large hip joint effusion may be decompressed in the bursa, as in cases of rheumatoid arthritis, for example. Then osteoarthritis is diagnosed by plain X-ray, by CT, and by MRI as well. The most important issue in osteoarthritis is the joint space, which is narrowed. In cases of osteoarthritis, it is this particular area. In order to discriminate between the osteoarthritis, which is the primary, and the osteoarthritis secondary to any other abnormality in the femoral head. Then if you look carefully to these conditions, osteoarthritis and avascular necrosis. In osteoarthritis, this space is markedly narrowed. In avascular necrosis, no, this space is not narrowed. It is narrowed in primary osteoarthritis with development of subcortical pseudocystic changes, sclerosis, and so. But this is the flattening and the collapse of the femoral head with sclerosis and fissures, diagnostic of avascular necrosis. Loose bodies are usually secondary to osteoarthritis, but may be secondary to trauma, pigmented villonodular synovitis, avascular necrosis, and any type of arthritis. Loose bodies are usually diagnosed by plain radiography, but can be seen by MRI. And this is a case of synovial osteochondromatosis of the hip, where you can see too many loose bodies within the hypertrophied distended joint capsule. And this is a case of synovial osteochondromatosis. You know that this is the result of cartilaginous metaplasia, resulting in loose bodies that later on calcify, resulting in widening of the joint space, bone erosion, and intra-articular too many loose bodies, ending with secondary osteoarthritic changes. And this is synovial osteochondromatosis with too many loose bodies in the hip. Then finally, how to measure the femoral neck anteversion angle. Many times you are requested to measure the femoral neck anteversion angle, and it is done by CT in a simple way. Just to put the patient in the supine position, in a symmetric position of his limbs. No limb is forward than the other. Then you scan the region of the hip and scan the region of the knee. Then you select the image of the femoral neck and the image of the femoral condyles where the patella is optimally seen. Then you draw a line just in the middle part of the femoral condyle and another line in the middle part of the femoral neck. And you extend these two lines until they meet, or you can have this overlapping image, this line for the femoral neck and this line for the femoral condyle, and you measure the angle in between. This is the normal range of the angle by age. It decreases by progression in the age. This is the normal angle in the age of 1 year, and this is the normal angle in the age of 20 years. This is another more easy way to measure the femoral neck anteversion angle. You got a scan in the femoral neck and a scan in the femoral condyle, and you put the two images beside each other. You draw a line tangential to the femoral condyles and a line cutting through the main axis of the femoral neck. Then you measure the angle in between these two lines. Then you came to the questions. Yes? Osteoarthritis? Avascular necrosis. Osteoarthritis or avascular necrosis? Avascular necrosis with secondary osteoarthritis. The femoral head is irregular in contour with sclerotic reaction. This is stage 4. Okay. It is not slipped, but whenever you see the epiphyseal line, don't ask about the age. And in examinations, they usually consider this as a big mistake, because the major difference between the ages lies in the fusion of the epiphysis. Before fusion, certain diseases; after fusion, other diseases. Then this epiphysis is affected in this particular area, and the metaphysis is okay. Then you are dealing with Persis disease, and you see in the frog position or the lateral view. Okay. Then what do you think about this case? Okay. You got bone marrow edema of the femoral head and the neck, which are bright in the stare, but look at the acetabulum. There is also bone marrow edema in the acetabulum. Whenever you got this appearance, and you know that the affection of both sides of the joint line is disease of the joint, or you consider the possibility of trauma. This is the only two ways. If you got affection on either side of the joint line, you consider joint disease, arthritis, and so. Then if you see this CT, and you can reach the diagnosis, which is a fracture of the acetabulum with post-traumatic edema of the iliac bone and post-traumatic edema of the femoral neck. Then slip the capital femoral epiphysis, avascular necrosis stage 2. Very good. Muscle injury, which is stage 2. Hemorrhage, bright in the T1 and bright in the T2 weighted image, stage 2 muscle injury. Fracture and this hip is not dislocated, but there is comminuted fracture of the acetabulum and yes, hematoma. Where? Yes, in this area, in the obturator internus, with displaced bone fragments compressing the urinary bladder. This is very important for the management of the fracture itself. Okay. Transient osteoporosis, left or right? Right. Very good. Yes, Iliopsoas bursitis. Very good. Okay, marrow infiltration. Okay, you consider lymphoma. Let's look at the femoral neck and the shaft and the T1 on both sides. You got almost similar lesions, but this is more black than this one. Okay. If you go to the T2 weighted image, both lesions do not become bright, meaning that there is no bone marrow infiltration. If this is a disease, you got increased signal in the two conditions. But this is the red marrow, the residual red marrow, which does not significantly increase in signal in the T2 or in the stare images. Then why this is more black compared to this one? Yes, what do you think? Patient position in relation to the coil, and that's all. How can you confirm this? By the stare image. Whenever you have the stare image, you got no brightness at all. Then you know that this is the residual red marrow. Yes. Okay. Slap the capital femoral epiphysis. Left or right? Left. Okay, and it's clearly seen by CT. a vascular necrosis. Do you see the line? It's very dangerous to diagnose a vascular necrosis without the line. And you should have other imaging, other pulse sequence. This is T1, of course, and you should have the T2. You may got some brightness here, and you can easily see the line. If you are sure that this is there is a line here, then you start to diagnose the vascular necrosis. If this is black in the T1 and bright in the T2, you can reach the diagnosis of stage 3. Yes, stage 1 muscle injury, no abnormality in the T1, brightness in the stair, and stage 1 muscle edema. Versus disease. Versus left or right? Left side. Then look at the plain X-ray. This patient was referred to me by this plain X-ray to do a CT scan. And the lesion is more evident in the plain X-ray than in the CT scan, even after reconstruction of the images. And this is stage 1 versus disease. Sorry? Osteochondral? Osteochondromatosis. The fracture. Where is the fracture line? Yes, this one. This is just the muscles and the capsule, and so this is the fracture line, and in the posterior column of the acetabulum. Infusion only?
No, the bone marrow also.
Bone marrow? Hip arthrogram. Okay, hip arthrogram. What is the pathology? Labral tear. Superior or inferior? Inferior. This labrum is torn? Or this one? The superior. Okay. This is the torn superior labrum with some osteoarthritic changes. Okay. Vascular necrosis is stage 2 because of the normal bone marrow within the line. Yes, a vascular necrosis is stage 2 also. Same. Fracture? No. Don't diagnose subcortical fractures in the pediatric age of group halls. Don't do this. And subchondral fractures are usually stress fractures, and they need that the epiphysis is fused in order to care. This is fissure due to a bursitis disease, stage 1 bursitis disease. A slip decapital femoral epiphysis, unilateral, bilateral. And the slip, the epiphysis is pinned. You see the pin? And this is accurately positioned pin in the center of the epiphysis, and this is abnormally positioned pin, which is in the inferior part of the epiphysis. This is the wrong position, and this is